Welcome to episode 2 of Vital Voices. Today we're addressing an incredibly important health topic, breast cancer screening. Joining us are Wemyss, Operations Manager with responsibility for imaging, and Dr. Carnille Farquharson, Family Medicine Specialist, both from Oaktree Medical Center. Together, they'll guide us through the ins and outs of breast cancer screening, from why it matters to what you can expect at every step. We'll discuss the latest advancements in imaging, the role of self-examination, and how to have proactive conversations with your primary care provider about screening. Whether you're new to breast cancer screening or looking to deepen your understanding, this episode is packed with essential insights to help you stay informed and empowered in your health journey. Let's dive in. Welcome to Vital Voices. We are excited to continue on this journey into discussions about healthcare. Looking at breast cancer screening. I know we're into the month of November now, and people may be like, "Oh, why are you still talking about breast cancer and breast cancer screening?" And that's because, in short, the movement continues. Oaktree Medical Center has continued their Million Mammogram Movement initiative. And as such, we found it right to continue the conversation with the team at Oaktree. And I'm pleased to be joined today by Dr. Carnille Farquharson, Family Medicine Specialist, and Wemyss, who is the Operations Manager with direct responsibility for the imaging department. Welcome to the Vital Voices show, ladies.
Thank you.
So we wanted to talk about, today's episode is titled Breast Cancer Screening from A to Z. From my conversation with Dr. DeVoe, on last week's episode, one of the things that kind of stuck out to me was something he mentioned indicating that, a lot of women still aren't quite aware of when they're supposed to start screening, what the purpose of the screening is, the importance of doing the screening every year. So we felt it fitting to continue this conversation and kind of dive a little bit deeper into this process of, what goes into getting your mammogram done or any additional screening that you might need as you think through going through the process of, just finding out what's going on with your body. So let's start at the beginning, because I know we touched on it a little bit last week, but why is breast cancer screening so crucial?
Okay, so the bottom line is that screening picks up any type of condition at its earliest stage. And with breast cancer, the earlier that you can pick it up, the easier it is to treat, and with less cost and less complications to the patient.
Okay. And I know there's a lot of different screening methodologies that are available. Mammograms, from what I understand, are the gold standard. But what are the current recommendations for breast cancer screening by age and risk factors? Because I know, we continue to see numbers where we're finding breast cancer in women younger and younger, especially in our country, in our environment, in our demographics. So what is the current recommendations for screening by age and by risk factor?
So depending on which specialty you're in, family medicine versus OBGYN or other specialties, they may or may not use different guidelines, international guidelines, either from the US, North America, Europe. But as a family medicine doctor, I typically go by the AAFP, but obviously we have to adjust based on what the risks are for our own population. Right. So generally, you would usually advise an average risk woman or man for breast cancer to get their initial screening at age 40. Then you can do the second one at age 45, and at 50, you start every year after that. For women who are at higher risk for breast cancer, and when I say higher risk, I mean you have a positive family history for breast cancer, and especially early breast cancer in the first degree relative, and that would be your sisters, your parents, grandparents, immediate aunts and uncles. You would want to start earlier, and sometimes you would find them starting as early as 30, 35, and then based on all of their risk factors, that's the presence of the mutated BRCA genes, families, lifestyle, including smoking, exposure to estrogen hormones especially, your doctor will personalize the best how your screening should go after that. But generally, an average risk person by 40, you should at least have your first mammogram screen by.
Mm-hmm. So do the recommendations indicate, because I know 40 is the number that, obviously, October is a big promotion every year for a lot of different healthcare facilities. And 40 is usually the number that you hear. But given that, especially I think as people start to navigate the cost of accessing care, do the guidelines allow for, does insurance cover if you decide, if your physician says, look, you're at risk because you had a mom or a sister or whatever, are you able to access it through your insurance? Especially, I think that's a part of the conversation that people want to know about, and get it covered at an earlier age if you're not 40 yet, because you have these higher levels of risk.
Well, definitely a discussion can be held with the insurance company for coverage. However, 40 is kind of a cutoff age as well for mammograms specifically, because at earlier ages, the mammograms tend not to be as good in picking up cancers just because of the density of the breast. Younger women tend to have more dense breasts. So a discussion or requisition from the insurance could potentially be covered. I don't know. It just depends on the insurance company. The younger the woman is, though, you would usually start with something like a ultrasound scan. And then in more recent times, the MRI mammogram is also becoming more mainstream in terms of how much better it picks up, especially in younger breasts. However, the difference in cost can be substantial. I definitely don't think insurance companies cover the MRI mammogram, but they would potentially cover the ultrasound scan.
Okay, understood. Because I mean, like I said, coming out of some of the statistics that are out there, especially in our population where, our average age of detection is 42, which means we obviously have a number of women that are falling into that, sub 40 category in terms of being younger than 40 and are finding that they have breast cancer. Perhaps there's a discussion there to be had around, in certain circumstances, trying to make that more accessible for women, especially because of the potential risk of, finding it later. Obviously that's a big part of this conversation is, early detection is always a key component of any sort of medical discussion, but especially in when we were talking about cancer, I think the earlier the better.
Right, exactly. And it should work out much better for the insurance company as well, because again, the earlier you catch it, the less cost will happen.
Right, because it's less costly for the individual and for the insurance company, right? And that's true. It's a good way to look at it. So, let's take a step back, because I think a lot of times too, when you hear people have conversations about screening, a lot of it starts at walking in the door of an imaging center or a health facility that has imaging to get a mammo done or a breast ultrasound or something in that space. But let's take a step back, because I know there's a lot of discussion and conversation, especially I imagine in the family medicine space, around the importance of self-examination. So how important of a role does self-examination play in detecting some of the early signs of breast cancer? And then what should women look out for? So let's say, you have someone who's listening and they're 30, 35, and they're like, well, I'm not sure if my insurance is going to cover it just yet, but I want to kind of have an idea of what's going on. What would you recommend for someone who's in that sort of a space?
Okay. So in many decades gone by, breast self-examination definitely was one of the things that was encouraged to help pick up, any disease of the breast, but specifically breast cancer. We know now that breast self-examination, unfortunately, does not catch breast cancer in most cases early enough, especially with other imaging studies available. And so family medicine, you will still find many doctors still encourage their patients to do breast self-examination. It does encourage women to become more familiar with their breasts, and it can definitely pick things up. In the case of cancer, though, we would definitely want to encourage you to more do the imaging studies for it to pick up at a much earlier stage. Because unfortunately, by the time a lump becomes apparent in the breast, particularly a cancerous lump, it's usually at a later stage. And so, the treatment as well as the complications for treatment will be at a later stage than if you pick it up, say, with a mammogram or MRI. So we don't discourage breast self-examination, but we need women to understand that if you're looking, if it's a case of especially high-risk women with strong family history of breast cancer, they in particular need to go for imaging studies as opposed to just relying on the self-examination.
Yeah. And I imagine a part of it is, I think you touched on it a little bit, is if you know what normal feels like, then it makes it easier if something feels out of the ordinary, if you're routinely doing self-examinations yourself.
And just to also point out that a lot of women feel that the only sign or symptom of breast cancer is a lump, and that's only one of the things that cancer can show up as. The other things that you would want to look for is any specific changes in the breast, like for example, the nipples may become inverted. There may be skin changes. You may know changing of the skin, dimpling of the skin, discoloration, and also nipple discharge. So, just thinking that a lump is what I need to be feeling for, but you also have to look for any of those other changes that could potentially be cancerous or some other breast disease.
Okay. As a family medicine physician, obviously you play a big part in the role of primary care. For a lot of people, you would be the first physician that they see before they go any further into engaging with healthcare. What role do you play and other people who exist in the family medicine space, in the primary care space, in educating and encouraging patients about breast cancer screening?
Okay. So again, primary care, family medicine, we should be well versed in preventive medicine and should know for any age group, particularly in this instance, women and men. Again, I must emphasize, men do get breast cancer, so they should also be looked at if they have a strong family history. It's in terms of discussing long before. It's expected that certain things may show up, to keep priming the patient to know what they should be looking for, what testing they should be expected to do at certain ages, and kind of where to go from that point. But mostly it's in terms of teaching them what they should be doing in terms of looking for certain diseases, and also encouraging a healthy lifestyle as a preventive medicine for all of these things developing.
Okay. Imagine we'll circle back around to the lifestyle part of this conversation a little bit later as well. But how can patients have proactive conversations with their primary care physicians about screening and risk factors? Because I mean, this might sometimes be more problematic on the man side of the equation, because men just generally speaking tend to be a little bit less, in tune with our health. We only show up at the doctor if something is catastrophically wrong, right? But even still, if you have a woman who maybe has had, because people go through a lot of different and interesting interactions with the healthcare system, especially in recent times. So how can patients have proactive conversations, just so they are aware and they know how to ask the right questions in order to make sure that they're being proactive about their own health? Right.
Yeah. And unfortunately, like you touched on, a lot of people are not aware of what could potentially be happening. I mean, a lot of them, they start thinking of a particular disease when a family member or a friend or someone else develops or something happens to them, and then they start thinking, oh, I'm that age, could it happen to me, that kind of thing. And that may be a lot of people's first thoughts about, okay, I need to go in and maybe talk about this and see if I'm at risk for this. But it's never too early to bring up conversations, and it's always good if you do have a regular family physician or primary care doctor that you go to and you're comfortable with them, and just ask them. You don't have to be specific in say breast cancer or prostate cancer or whatever, but just specific in for a woman like me, what kind of things should I be concerned about in terms of my health? And that could vary anything from other chronic conditions to breast cancer. So
because sometimes people only show up even in that instance, like you say, they show up when there's something wrong, even if it's not catastrophic. It's like, okay, so I have food poisoning, so I show up to the doctor, or I have a really bad flu, so I show up to the doctor, but not necessarily kind of keeping in that regular touch. Because I imagine it's not always the easiest thing to interact with the healthcare space in general. This is not even like specifically to a physician or any one physician, People, for those of you who don't know, if you've ever been to the doctor and you got your blood pressure checked and it was just, in that moment, uncharacteristically high, it's the thing called white coat syndrome, right? So you in there, right? You in there and you just anxious because you at the doctor at all, right? But I think it's important that people understand the importance of engaging regularly with that physician, because a part of it is you develop a rapport. So if I come and I see you every year for my annual, I'm going to feel more comfortable to say, hey, this is just one thing that just kind of is a little bit different that I've been experiencing. Whereas, if the only time you show up and it's always a different physician, because this time you go to this place and this time you go to the next place, by the time you come back around, it's like, well, okay, I don't really feel comfortable talking to you about this thing because, well, it's the first time I've seen this particular physician. And I think that's a part of the importance of having a specific primary care family medicine physician that you go to as your initial point of contact. I know obviously with a lot of women, for them it's their OB, but it's still the same thing. If you're keeping that consistent interaction, it makes it easier to have what might be an awkward conversation.
Right, exactly. And just to add to that, not just the patient being comfortable with the physician and being able to talk about certain things over the years and getting more comfortable talking about more private stuff, but also the physician maybe noting some changes in the patient that the patient themselves may not notice, and then at some point you're going to ask, well, I've seen this, and based on your notes from last year, this and this was the case, but I'm noticing a little something different. What's been going on? Tell me this, tell me that. And also, as the patient gets older, we know that their risk for a lot of other different things start to increase. And so we know at certain ages, we need to start bringing up those conversations.
Right. So yeah, it's that idea of, the importance of, having a consistent history with a patient. Because like you said, you get to pick up on these little things that, because you have data that's going back 5, 10, 15 years, you have a fair amount of information to go off of. Right. Okay. That's good. So, I mean, obviously we tend to want to continue this conversation about the importance of primary care, the importance of getting your annual physical as a part of any preventative health measure. But kind of looking back now, that somebody's gone through the process, they've seen their primary care physician, and they're at the stage where, okay, I need to come in and actually have a scan done. So Mona, I kind of want to, have more of this conversation with you. But what does that process look like for someone who's coming in to get a scan done? So let's start with just generally speaking. I know Dr. Farquharson mentioned you have a number of different modalities. You have the mammo, you have the ultrasound, the MRI. What are the different options that are available? What's the difference between a 2D mammo and a 3D mammo? What is all of that? Because it can kind of sound like there's just alphabet soup of options that are on the table, and you don't know at which point you need this one versus that one. So, just walk us through what those modalities are and what they mean and how it operates in each sphere.
Let's just say your physician gives you a requisition just to have a routine mammogram, because sometimes you just, your physician will say, or the insurance company, most of the insurance companies offer a mammogram every year with their plan. So let's just say a patient walks in to have a mammogram. A 2D mammogram versus a 3D mammogram. A 2D mammogram only gives you the basic of the images of your breast. A 3D mammogram is more invasive, and it gives you a better picture of what your breast should look like and what's going on with your breast.
I have a reference point, but I'm not sure if it's going to resonate with everybody. So in my mind, when I hear 2D versus 3D, what I think is 2D is you're playing Super Mario World on a Super Nintendo. And 3D is like you're playing, Super Mario or Halo on Xbox, as an example, right? You're talking about just the difference in the clarity of what you can see, I imagine, is what it really is, right? Okay. Yeah, sorry. I mean, I only have the reference point that I have, right?
And trust me, depending on the patient, sometimes you have to use real world references that they can understand better. Although Halo, I'm not familiar with that.
Right. So that explains 2D versus 3D. Where does the ultrasound and the MRI then come into play?
The difference between an ultrasound and a mammogram. The ultrasound are sound waves. So the ultrasound would give a physician can I say a better view?
A better view, and based on the density
Of the breast.
of the breast, as well as the actual mass or what you're looking at, because sometimes breast mass may have fluid in them. Ultrasound show that much better. But specifically for when we're talking about breast cancer screening, using the ultrasound versus the mammogram is just the breast density. So younger women, you would more go with the ultrasound scan, whereas the older women with less dense tissue, you go with the mammogram. And the MRI is better than both.
Right.
However, and would be much better for the denser breast as well, because it can really pick it up. You know, the imaging is really good. Right. Again, it's very cost. Again, it's much more expensive, and especially for younger patients, if you're not having insurance or you don't have the money to pay for it, it's not.
It could be a prohibitive, right? It could be a prohibitive factor. Yeah. Understood. All right. So is there an instance where, you know, someone comes in there, they do the mammo, and to some degree it's inconclusive, and it's like, okay, so you may need to do an ultrasound on MRI. Is that something that happens?
Yes. Most times. Yeah. A lot of times, after a mammogram is done, a lot of reports come back for a patient to have an ultrasound.
Yes. And that's just that, you know, depending on every woman's body is different. And sometimes there may be tissue that the mammogram is really not good at penetrating. And so it's really just not giving the best outcome. And so additional imaging would be requested.
So from a layman's perspective, what it sounds like is the mammo is kind of that cross section of, it can give you a decent enough scan at a cost that is not a barrier to entry for most people. Yes. And therefore that's the value in having a mammo versus making the MRI the gold standard or the ultrasound the gold standard. Understood. Okay. So I think we kind of covered the idea of where each type of scan fits into play. I imagine as someone who works directly in the imaging space, you've gone through and seen a lot of women go through the process of getting a mammo done. I know I've heard female friends of mine who have mentioned, you know, kind of just the concern of when you go to do that mammo the first time. What is the experience like? You know, because I think sometimes there's this fear of, is this going to be painful? Is it going to take long? You know, how's my body going to feel going through this process? So what would you say to women to kind of walk them through, especially someone who may be at just the first time they're getting their mammo done, to make them feel at ease in going through the process?
I would say for most women are afraid because they have this image in their head that they're just going into a room and they're going to have their breast mashed or smashed.
Yeah.
So to make them comfortable, our text would explain to them the procedure before they go in, that we're going to, I'd say, put your breast on the machine, but it's not going to hurt. Because for most people, they think that it's painful, but it's really not painful when you go through the process.
Yeah, I think a lot of the anxiety kind of like the same way the anxiety causes your blood pressure, you become more aware of everything. Yeah. Causes your blood pressure to go up. It makes you kind of like the unknown. It does the same thing. But in terms of like the length of the procedure, what, like 20 minutes?
About 20 minutes.
About 20 minutes.
Basically.
Yeah, and the patient will go in, they will undress from the waist up and put on the gown. The tech should explain the process to make it a little bit more, so that they will know what to expect, and the anxiety is less. There are 2 plates.
That they squeeze together.
A bottom and a top plate, and the breast is put on it, and in order for the mammogram to penetrate the breast does have to be as flat as it can be. And from my personal experience, when I see that plate start going down, I'm thinking, is there like a fail-safe mechanism where something goes wrong with the machine and this just keeps flattening? So that's in the back of my head. I know my blood pressure is up, right?
And for most people, that's what it is.
That's what I think. But you know, it's controlled, and it will go as far as is comfortable and the imaging. Depending on the size of the woman's breast, you know, the density, you know, the flatness will be relevant. I mean, relative. So that's what's going to happen. They're going to do one breast at a time, and then it'll be over.
Is it more painful if there is something there?
Sometimes it may be more painful. Well, definitely it would be painful if something is there. That would probably be the reason why they were sent there too.
And also, like for women who are still having their periods, it's probably best to schedule your mammogram like a few days after your period starts, because just before, like maybe for about a lot of women, like up to 3-4 days before your period starts, and for the first couple of days afterwards, the breast is swollen and tender, and so that is definitely not the time you want to do your mammogram. So, well ahead of your period, you want to have that done. It'll definitely be more comfortable.
Okay. So in this process, who decides what modality of imaging is best for each patient? Okay. Continuing along the conversation around the technology of screening, obviously I imagine at some point, you went from 2D to 3D. What are some of, the more exciting advancements that are taking place in the field of imaging as it pertains to cancer screening, breast cancer screening? Is there anything on the horizon that you're looking out to see, like that's going to increase detection rates, anything like that, that people should be aware of, or that you're just excited about being in the field?
Well, for now, the 3D mammogram has just come around, and that's something that's been exciting for the imaging world for now. What we are looking at and what the whole world is looking at this time is AI, and what AI will come up with for it. So,
okay. I mean, I guess that is a key conversation in healthcare, is the role that AI can play. I guess both in an advancement standpoint for technology, from a technology standpoint, but I imagine also from being able to crunch tons of data to be able to say, if you've seen this particular minute thing and you've seen 100, 1,000, 10,000 of these, in these instances, this means this, then there's this assistance in being able to better detect from that standpoint. I imagine something that might just, maybe the human eye may not pick up, but AI in combing through decades of
information. For sure, that's definitely something. Like at this point, in terms of being able to interpret all sorts of different things that can be going on in the breast, and to regenerate that image the way it needs to, and for a better interpretation.
Okay. You mentioned 3D mammo being exciting in that space. How has that technology changed the landscape of screening? Like, have we seen a drastic increase in detection rates because of using 3D mammos versus 2D?
It has been a drastic change since 3D has come on stream. There isn't that many 3D machines on the island, if I must say. I think we have 2. Doctors just recently got theirs. Fort Terrace has one, and I can't think of any other. Maybe family medicine.
Right. So there's not a ton of 3D machines here. Locally.
Definitely, the family islands have been.
Right. Okay, fair enough. So I think we walk through the process of what people can expect as they go through. What is the process after you've done the screening? Like, how long is it typically before you get your results? What type of follow-up procedures are in place? What does that normally look like? Because I think if people can understand, okay, why do I need this particular modality? What does that look like when I go through it? And then what can I expect on the other side? So we're at that point. What can women expect on the other side of having done their screening?
Okay, so definitely the next step once the result is available, and it just depends on the imaging getting to the radiologist who will interpret it and provide the report to the physician. And then having a discussion with the patient, your primary care doctor having a discussion with you. Again, just reinforcing why it was needed based on their risk factors, what the interpretation of the imaging study said, whether it's the breast tissue may have some abnormal tissue but is not cancerous, or if there's a suspicious lesion that they were not able to say for sure whether it's benign, that is non-cancerous versus cancerous. There are a lot of other things in the breast, fibrocystic breast disease, all of those things, those can be explained. But definitely if it's something that looks to be cancerous, then the next step would be to, basically breaking that news gently to the patient, because again, they're coming back feeling very anxious, especially if they were high risk. It's always good if it's a possibility of cancer for that patient to have someone with them, to be there with them and discussing what's going on, because half the time the patient may not even be, they're just not really hearing all the stuff, because they're panicked and anxious, and so that other person can help with gathering information and be a source of comfort as well. And then depending on the patient's age, in terms of either you're going to do further imaging. For example, if it was in the case of a younger woman, did ultrasound scan. Like I said, in our situation, I don't think there's an MRI mammogram. That would have been the best thing for them to do next. Or if they have access.
They do have an MRI breast
mammogram.
Yeah.
Oh, okay. Yeah. So that would be the next step for, say, a younger, just to give a better definition.
And sometimes there's a breast biopsy that they would perform.
Yeah. So there are several different types of biopsies. You can have your fine needle aspiration, where a needle is used to usually we call it ultrasound guided. Yes. So you have to go back to the radiography place with an ultrasound scan. The radiologist will direct the needle to get a sample. You can have a core biopsy where it's a hollow needle that's inserted again, ultrasound guided, and take a core off the mass, whatever it is. Or sometimes you're referred to a general surgeon or a general surgeon to do a core biopsy, or to do a lumpectomy where they go in and remove the lump, and then however the specimen is gained, that is sent to the lab. Yeah. And to give a definitive diagnosis. And so, the process, depending on which step you have to go in, the fine needle aspiration versus actually going to a surgeon and having a surgery done, can take varying lengths of time.
What is the typical turnaround time for the results from a biopsy?
2 weeks. How about that?
So I imagine from both vantage points, you probably experienced a fair amount of women coming out of a screening and having results that are abnormal to some degree. How do you address patients' concerns or anxieties when they get an abnormal result? Because obviously we know breast cancer, especially for our community, has a particularly difficult history. For a lot of people, you have a lot of people who have had family members, loved ones, friends who passed away from it. So how do you navigate that? Because I imagine it's a difficult thing to engage with a patient when they've had an abnormal result and it's looking like that's the direction that it's heading in.
Yeah, it's never an easy conversation, and especially depending on the type of support that the patient has, whether it's family or friend support, and also knowing the patient's ability to access certain treatment. all of those things are crucial in being able to have a conversation, because we know what should be ideal for a particular patient. But if that patient doesn't have the finances or otherwise to go that route, then we have to start talking about alternative steps. And so all of this stuff is going on in terms of the discussion. So it's never easy, but you have to be fully open and honest with the patient in exactly what these things could potentially be. Give them all of the treatment options, and they have to, so that they have enough information that they can make an informed decision as to which pathway that they're going to go. And just be there as a support for them, whatever questions they have. Sometimes some people may make a decision right away, and then other times some people need some time. They need, sometimes they just don't want to think about it.
Right.
You just have to be there for them until they make a decision.
And it's very important to follow up with them, because
Mhm.
sometimes they will not follow up with you.
Mm-hmm.
So it's very important to follow up with them.
Because I was going to ask that, like, what are the most important steps for follow up after a mammogram, regardless of the results?
Mm-hmm. Regardless of the results, it's just continuing to have,
Your
relatively
regular check.
quick follow-ups with the patients, depending on what the results are. If they've had to go to, if it's definitely cancer, you need to be in contact with the surgeon. If they had to go to a surgeon, with an oncologist, if they had to go to, obviously an oncologist, and be in contact with the doctors. And after each of whatever treatment they have with their other doctors, then you as a primary care doctor want to have that patient come back, see how they're doing, how they're faring. Particularly if they have other conditions, you need to see if you need to alter anything based off those conditions, based on what's happening with their cancer treatment.
Is that right? Because you then have to start to think about drug interactions, things like that, I imagine. Because that was another question I had. What is the importance and why is it crucial to have continuity of care with someone who maybe has gotten a diagnosis coming out of a mammogram?
Right. Yeah. Just in keeping in contact to know for sure what the other doctors are doing, because you can be the most intelligent person, in terms of the field that you may be in, but when it comes to medical information and terminology, sometimes you're just not understanding what's going on, and you need someone who you're comfortable with to break it down for you,
Right.
to explain things, and then sometimes patients may not be comfortable asking other doctors certain questions about the treatments that they're going through. And so coming back to your primary care doctor, you can specifically ask them, well, this doctor said this, that, or the next, and this, but I didn't really understand it. I didn't want to ask them, can you tell me what this means? And so all of those things, and helping to keep the anxiety and fear at its minimum as best as possible to help through the process, because it's not just a physical process, but it's an emotional, psychological process, and you need to be able to have your mind at ease as best as possible when you're going through these things.
You mentioned something earlier, and I wanted to circle back to that just as a question about any potential other myths or misconceptions. So obviously you mentioned that a lot of women feel that the fear and the anxiety is that, like I think you said that the breast will get smashed in the process. But what other myths or misconceptions are out there that you've encountered, either from the imaging perspective or from the physician's side of things, that women have and, that you want to address when you have an opportunity to kind of dispel some of these myths and misconceptions?
One of the myths that most women have when they first find out that they have a lump, their first thought is, oh, I have to get my breast cut off. Mm-hmm. Before they even do any type tests or check to see what type of lump it is or anything like that, their biggest concern is, oh, I have to get I can't get my breast cut off. But you don't have to get your breast cut off. It doesn't happen.
Yeah, nowadays there are a lot more technology and treatment options, and it may not even be cancer, so still come and get your screening. But other things that women should be aware of is that one of the things I said earlier is that the breast self-examination, which has been pretty popular in a lot of annual exams, realize, especially for high-risk women, that it's not enough. It is definitely not enough because it's going to pick up a lump too late in the disease process. Other things are that only older women get breast cancer. Well, in our community, we know that's just not the case. And in fact, the younger you are when you get breast cancer, it tends to be even more aggressive than if you get it at an older age. So you need to be even more aware of that. Breast pain is only if I have pain. It's cancer. No.
No.
Pain is actually a very, very late symptom of cancer, breast cancer. And so, yeah, don't wait until you start feeling pain to say, I need to go and get my breast checked. So those are some of the more, I guess.
Yeah, I mean, I think sometimes people approach healthcare from a very I guess from a place of mistrust and distrust. So I think the idea sometimes people have is, they're just saying that you need a mammo because it's a way for them to make money. But I think, especially when you look at the statistics in our country, I think Dr. DeVoe mentioned that the average rate of the average age of detection in the U.S. is 62, and the average age of detection here in the Bahamas is 42. That is a very big difference, right? And so, that when you look at that in particular, this is why it's important to get your screening done. It's not some cash grab. It's the gold standard, and the recommendations are what they are because it can be very deadly. And so you want to catch it as early as possible to have your best chance at fighting it off.
Because you don't have a family history either. Because a lot of people think because you don't have a family history, then I don't need a mama.
Right. No, I mean, I think I've said this in a couple of different, I don't think I've mentioned this part of it, but like my mom she got breast cancer in 2021, and there was no family history. There was no, to our knowledge, there was not my grandmother, not my great grandmother, none of her sisters, none of her aunts. There was no history, and it took her in a year and a half, right? And so I think from that perspective, I always tell people, you have to think of it from that standpoint. You could just be the first, right? And don't look at it from this perspective of, well, mommy didn't have it, and auntie didn't have it, and sister don't have it, so it's fine. Now, granted, obviously, we know of families where mommy had it, and auntie had it, and sister had it, and so and Grammy had it, and we look at it like, well, no, but you just never know when you might just be the first one in the lineage that gets it, unfortunately.
Exactly. Yeah.
But it's not a death sentence.
It's not. That's the thing, right? There's a lot of factors, I think, and we're going to have a conversation with Dr. Knowles Robinson and Dr. Johnson Deems in a future episode talking about the psychological component of navigating things like breast cancer diagnoses and treatment and all of that, both for the patient and for the family members and loved ones who are there to support. But that is a critical part of it, is how you gain support and how you get support through that process, because it's definitely not something you should find alone, right? And I always tell people, I think I look at the story of my mom. My mom found out literally, I think we had either just shut down for COVID or we shut down right after she found out. And so all of the typical in-person interactions and engagements that you would have for support, a lot of that was stripped away because there were all these restrictions. So she couldn't just like walk into a sister group meeting. She couldn't just, have people come over to the house. There were all of these things that restricted people from having interaction. And that played a very key role in how she navigated the disease. And so, yes, it's by no means a death sentence. And that's why, again, the earlier you find out, the better it is, because you have a more of a fighting chance. So as we wrap up, what advice would you give to women who are hesitant about getting their breast cancer screening done, who are hesitant about getting their mammo done? What would you say to them to encourage them to do it?
Well, I mean, from a physician standpoint, it's heartbreaking when people wait to either access care for something they're concerned about, or to actually get treated, and you see them later on after complications and costs. And so the earlier that you were, that you're able to be diagnosed, the better. Seeing it on both sides, the complications of going through surgery, sometimes the cost is prohibitive, sometimes the treatment that's available here may have more side effects than, say, if you were able to get it otherwise. So preventing having to go through too much treatment is better than just kind of saying, well, I'll just wait, and if it happens, it happens. But let's all accept that it's a very anxiety-ridden decision to make, even just to go in to get screened. We know that. But in the long run, it's just going to work out so much better for you. And sometimes, the anxiety of not knowing is just as bad or worse than going through the process. So just get it over and done with, and have a better psychological
right. You'd
preparation,
encourage people just go and have it for one time. And after they go and they get over it for the first time, they most likely will go back.
Because sometimes that's what it is too. It's just like, okay, that overwhelming anxiety of I've never done this before. And I imagine, like you said, once you've gone through it, you kind of feel like, okay, it wasn't so bad. And it's right. I mean,
so experience it for yourself.
Right. I think that's the other thing too. I mean, I know, obviously one of the big things for finding it early too is you have the opportunity to catch it before it spreads. If there is something, you want to know early enough before it starts to spread to different systems of your body, right? Because obviously once you get into spread, then it becomes exponentially more difficult to fight. Your mortality rate goes up. You have all of these different challenges that now come into play. So I think the one thing I would say is, what is, for each of you, what is your most important takeaway from this conversation that you want to leave people with, having gone through kind of the nuts and bolts of what the process looks like, why it's important? What would be your lasting message to women who are listening to this podcast, or men who are listening to it and may want to go and have this conversation with their loved ones?
For me, it'll be just go and have it done. It's very important to get it done. And you may save your own life when you have it done.
Yeah, and if you are a person who had a lot of negative conversations with others surrounding it, actively seek out a source that can give you a positive view on it. You mentioned the Sister breast group, the Cancer Society of the Bahamas. They have people there who can talk to you. They've gone through the process themselves. They know both sides of it. And so if it's a matter of just having knowledge or being less anxious about doing this, just speak to them. And then I see a lot of people who are anxious about it because of cost. Again, you can access certain stuff through different groups as well. So, try not to let cost prohibit you from being able to do these things. Whether you speak with the department to do a payment plan or otherwise. It's amazing to understand that there are a lot of people who actually don't do certain things because of the cost.
Can't afford it.
That's a very big thing. But just don't not do it because of cost either. There are ways of getting around that, or especially if you're at high.
Yeah, I think that's one thing to say too in regards to this particular issue in this particular space. Breast cancer is an area that has a tremendous amount of support. There's a tremendous amount of organizations that are actively seeking to provide support, both financially, socially, and all of these different ways. So it is something where there's typically always going to be someone or something around the corner that is in a position to provide some level of assistance. Whether it is from, like Sister provides people with the catheters to get the portacath put in, and different things like that exist out in the space. So there is that key component of of it as well. There's a lot of energy in providing support in regards to this particular issue.
Just like Oaktree, MMM 240.
Exactly. And it's a good thing to mention. Obviously, the conversation with Dr. DeVoe, he reiterated this is not a one-time thing. It's not just an October thing. It's an ongoing initiative to allow women to get their breast cancer screening done, get their mammograms done. So it's a good segue to let people remind them that you do have the opportunity to take advantage of the Million Mammogram Movement Initiative. If you have any questions, where can people reach out to get more information? Where can they find out about vouchers and about scheduling their mammo?
If you have any questions, you can always call our office, any one of our offices, but you can call our main lines at 322-114-546. Or you can reach out to any one of our offices. You can also obtain vouchers from Sister and the Cancer Society. Yes.
So I want to thank you both. This has been a very engaging and interesting conversation. There's some things that I've learned in kind of going through this with you guys. So I want to thank you for taking time out of your busy schedule to talk with us, to talk with our listeners. Appreciate that. And obviously, probably want to revisit this somewhere down the line, especially as the movement continues. But thank you so much for your time today.
Thank you too.
Thank you too.
That wraps up today's episode on breast cancer screening. We hope this conversation with Mona Wemyss and Dr. Carnille Farquharson has provided you with valuable insights into the importance of early detection, the latest imaging technologies, and the vital role of primary care in navigating this process. Remember, understanding your screening options and staying proactive with your health can make all the difference. Thank you for tuning in to Vital Voices. If you found this episode helpful, please share it with others. And don't forget to subscribe for more conversations dedicated to empowering your health journey. Until next time, stay informed, stay proactive, and take care.